Good afternoon, dear committee member, dear presents. My name is Zabihi, and I'm excited to take you on a journey through my PhD research focusing on novel insights into the neurosurgical interventions for patients with drug-resistant epilepsy. But first, let me provide a brief overview of our findings on the first project. Periventricular nodular heterotopia is a congenital brain malformation often related to drug-resistant epilepsy, and its deep-seated nature makes the traditional open surgery particularly challenging. Although minimal invasive techniques have emerged as an alternative, the optimal approach remains unclear. So to address this uncertainty, we conducted a meta-analysis to compare the outcomes of stereo-EEG radiofrequency thermocoagulation and MRI-guided laser interstitial thermal therapy. Our finding shows that the SEEG approach may provide better seizure outcomes. So in clinical terms, surgeons may use this approach. But to further strengthen our findings, multi-center RCTs with standardized long-term follow-up and comprehensive complication reportings are essential. Finally, policymakers should support further investigations to collect quality of life data and provide guidance for future clinical guidelines. My name is Zabihi. I'm a neurosurgery resident and a PhD student, and I started my doctoral studies with the aim to improve the quality of life for patients living with drug-resistant epilepsy, and my mission is to investigate novel interventions to improve the standard of care of these patients. Currently, we have two ongoing studies. The first project aims to investigate two interventions in a rare congenital malformation called periventricular nodular heterotopia, and the second project is dedicated to evaluating the surgical outcome in patients with mesial temporal lobe epilepsy. Let's take a closer look at the first study, which focuses on investigating the safety and efficacy of minimally invasive neurosurgical interventions in patients with periventricular nodular heterotopia-related drug-resistant epilepsy. Epilepsy is a global challenge affecting over 50 million people worldwide, and including 37,000 in Hungary. Periventricular nodular heterotopia accounts for approximately 3% of all epilepsy cases, and evidence suggests that 60 to 90% could achieve seizure freedom through novel interventions. The gold standard therapy, the open surgery, is rarely used due to the deep-seated and diffuse nature of the disease, which increases the risk of damaging eloquent brain regions. So minimal invasive techniques such as the before-mentioned SEEG RF-TC and MRgLITT have been emerged as alternative approach. However, there is a critical gap in the literature as no clear consensus exists regarding the optimal surgical approach. So we aim to compare the safety and efficacy of these interventions. As our PICO framework demonstrates, we are comparing two interventions to demonstrate and to show how the effect of seizure reduction and to assess the functional deficits. And we hypothesize that the MRI-guided intervention provides better outcomes. We conducted a systematic search across 3 major databases, found no previous meta-analysis. Out of more than 400 initially identified articles, 15 articles were included in the meta-analysis. Through citation chasing, we found one additional article. However, we were not able to retrieve it. Let me show the outcomes and the figures of the first project. So the first figure illustrates the seizure outcomes in between the two interventions. On the x-axis, we see the dichotomized angle outcomes, where angle 1 means free from seizure. And on the y-axis are the patients, is a proportion of patients falling into each category. Among patients receiving SEEG RF-TC, 54% achieve seizure freedom compared to the 35% in the MRI intervention. The second figure shows the predicted probability of achieving angle 1, so seizure freedom, on the y-axis, and it's plotted against the age at intervention on the x-axis. And it's also stratified by gender, females on the left panel, males on the right. As we can see, both interventions, marked by blue and red lines, demonstrates a nearly flat trajectory, which indicates that age at intervention has no impact on the outcome. Also, gender has limited impact, males having slightly lower odds compared to females. The last figure is simplified, as it doesn't contain additional predictors such as age and gender. And here we can see more clearly the outcome, that there is a 22 percentage point absolute difference between the two interventions of achieving seizure freedom, with 58% for SEEG and 36% for MRgLITT. The strength of the study includes being the first meta-analysis and including only individual patient data. The limitations are the small sample size, including only case reports and case series, and missing complication data. In conclusion, we can say that the SEEG RF-TC intervention consistently achieved better seizure outcomes, suggesting a potentially meaningful clinical advantage. Regarding the manuscript status, currently I'm writing the discussion part, and I plan to finish the manuscript by this weekend. The second project focuses on investigating minimal invasive surgical outcomes in patients with mesial temporal lobe epilepsy. Mesial temporal lobe epilepsy is the most prevalent form of focal epilepsy. Despite the adequate anti-epileptic drug therapy, more than 4 million people remain drug resistant, leading to several consequences. The gold standard therapy has been selective anterior temporal lobectomy and amygdalohypocampectomy, which can lead to several complications. So the previously mentioned two interventions gained proclivity to use them, but in the literature, we can see that there is a varying degrees of neurocognitive deterioration. So our study aims to compare the outcomes of these two interventions. We also use the PICO framework to compare these three surgeries. And as main outcome, we are interested in the cognitive outcomes measured by different neurocognitive tests. And we are also interested in the rate of postoperative seizure freedom as secondary outcomes. We hypothesize that the MRI-guided intervention provides better neurocognitive outcomes compared to the others. The clinical implication includes reduced treatment-related symptoms, and by recognizing these symptoms, we can provide adequate postoperative patient rehabilitation. Regarding the progress of the first project, the topic was found feasible, and we plan to continue it after submitting the first paper. In summary, both projects aims to address clinical gaps in the management of drug-resistant epilepsy. Thank you for your kind attention, and I would like to conclude this presentation with one of my favorite quote, which says, "You can't ever reach perfection, but you can believe in an asymptote toward which you are ceaselessly striving." And Now I'm happy to answer all your questions you may have.
Are you happy? That's good. Are we happy to ask questions?
Who understood it?
At least one from the left, one from the right, please. Until we get some questions. Is there still a role for MR guided What do you think? What is your opinion?
Is there a role?
Is there a position for the MR guided operation, or everybody should switch to the EEG guided?
Well, it's not a. No, we don't have a strong conclusion.
Okay.
So we didn't find statistically relevant conclusion, but we can say that based on the effect size, the absolute difference, this 22 percentage point difference, and also the odds ratio of 2.5, the relative difference suggests or indicates that the CEG might provide better outcomes, but we couldn't prove it. Also, I have to mention that we could include only 60, 70 patients, given the scarcity of data. This is a really rare congenital disease, so we don't found enough publications.
Arashk, I have a remark and a question. The question is, as I understand, both of these interventions are highly advanced technology and possibly they are not available at every institution. They must be quite complicated to perform, I can assume.
Okay. Yeah,
sorry.
I'm waiting for the question.
The question is, what happens to those people who cannot get this surgery?
So the traditional surgery is always available. We know they have some drawbacks. But fortunately, in Hungary, for example, we have the opportunity for the stereo-electroencephalography-guided radiofrequency thermocoagulation. So in Hungary, we have this opportunity. The MRI-guided intervention is much more expensive. You can find it in Hungary only in a couple of countries. And fortunately, by this study, we can not conclude that the cheaper the stereo EEG provides better outcome, but it shows a propensity that maybe. So maybe if we have a larger data, we can conclude and say that it is sure that the outcome in the CEG is better.
So maybe I misunderstood. Is the stereo EEG guided intervention the standard of care?
No.
No, and
yet.
then why didn't you compare the two novel approaches to the standard of care? So stereo EEG versus standard of care and MRG versus standard of care.
Because the standard of care, we know that the standard of care has a lot of complications. There are two novel interventions, and we don't know the efficacy is known, but we don't know the complications. And I wanted to know which intervention has more complication or less complication, which is better.
So my remark would be that I think you shouldn't call this an individual patient data meta-analysis, but rather a meta-analysis of case reports and series. So just to be a little bit more specific. Because then this would also give you the opportunity of putting your own patients from your own institution into the study. Just something to consider. Maybe if you need more patients in the analysis.
We couldn't compare it with the other interventions, so we could include only stereo EEG patients from Hungarian data. That was the main problem.
I see.